السؤال الأول للدكتور هيثم. In patient with primary infertility from Dr. Sham and has severe oligoasthenospermia with normal testosterone ultrasound and hormonal profile, is there is any role for antioxidant and what type and for how long?
So
You hear me?
generally, yeah. So patient who's having abnormal semen and normal hormone.
Yeah. Hormone normal, ultrasound normal. He has only severe oligoasthenospermia.
So usually the patient who, it is, as we mentioned, the guidelines, it's not clear that antioxidant have a really beneficial role, or we cannot decide which exactly patient will be benefiting from the treatment with antioxidant. But however, the problem that the antioxidants usually side effects are very, very minimal. And these patients, we don't have a lot of things to offer. There are some studies, like especially patient who's having severe, when we say severe, less than 5 million. So in these kind of patients, we expect that they are more related to testicular dysfunction. So these patients, I don't believe that they can benefit, but patient who's having moderate or mild defect can improve. And the most important thing that these patients should not be, especially if they're severe, they should not be delayed for XE. So the problem here that any treatment for male infertility, the cycle of spermatogenesis is at least 74 days. So we have to wait at least for 3 months to reevaluate. So in the study that we performed, we've seen that we avoided the patient with severe oligospermia, less than 5 million, and we have seen some improvement after 3 months or 6 months regarding sperm count, motility, and morphology, and DNA fragmentation. But we did not evaluate eventual pregnancy.
Thank you. Do you prefer any type of the antioxidant and for how long duration?
And this is one of the problems with the studies, because studies have shown like these, like the review article that I presented here in 2022, 90 studies, there are different kinds, tons of medications for antioxidant. So, and there is no, but that you can use, what I prefer is easy, like use a combination, something that have vitamin E, having levocarnitine, having zinc, having selenium, coenzyme Q10. There are some combination of these medications that available in one tablet, make it much easy to be used. So they have no severe side effects. They can be used, giving a trial for 3 months, especially if the couples, like especially the wife is young, and they are not willing to start XE immediately or go for assisted reproduction immediately. So you can give them the chance of doubt, especially that there is no a lot of side effects, and they can try for 3 months. This is the maximum that you can do. If you see improvement and they are willing to continue for another 3 months, this is an option that you can consider with them.
Thank you, Dr. Haytham. There is a second question from Dr. Sham regarding the empirical hormone for non-obstructive azoospermia before the XE.
Yeah, so I presented here 2 studies. One of them is the review article by Colby. So improving the testosterone level, improve the testicular sperm retrieval rates. And the other study, which is a very famous study by Dr. Hussein from Egypt with Neidenberger. And in this study, the patient who received treatment and they were followed regarding their response with a testosterone level and FSH improvement, these patients have a much better sperm retrieval rate compared to the patient who did not receive treatment. Finally, patient who's having normal gonadotropic and normal testosterone, now the AUA guidelines, ASRM guidelines, and EAU guidelines have clearly mentioned that FSH treatment can improve both normal pregnancy rate, improve semen parameters, normal pregnancy rate, and IVF outcomes. So these patients, I would consider giving them some treatment, especially having a negative TC is a very difficult scenario that you will be facing in these patients. But guidelines only accepted FSH treatment and accepted giving clomiphene, anastrozole, or HCG in a patient with having low testosterone before going to XE.
Thank you, Dr. Haytham. And we have a question from Dr. Muhammad Al-Marwani. What is the current evidence of the timing of varicocectomy in some fertile men with borderline semen parameters? And I will direct this question to Dr. Muhammad Abdul Rasul. دكتور محمد.
هو الحقيقه ما فيش ايفيدنس على التايمنج البروبر يعني for treatment or varicocectomy after diagnosis. However, if the patient have infertility, primary infertility, and we have the parameters in semen analysis that show stress pattern, and the patient has a varicocele. So do it right now. Definitely, it will increase the parameters of the semen analysis in up to 70 to 80% of the cases. So there is no guideline to define the proper time for interference for varicocele. So whenever diagnosed, go for varicocelectomy.
We have questions regarding the varicocelectomy in idiopathic infertility with normal semen analysis and hormones. Is there any role?
There is no consensus about that. However, if there is normal semen analysis, I don't do varicocelectomy. If there is normal semen parameters without DNA fragmentation evident, I mean the patient is normal, he has varicocele, don't interfere.
And this will take us to the second question regarding the DNA fragmentation test. Is this valuable to have DNA fragmentation in those patients with idiopathic and
yes, of course. If there is no evident cause for the infertility, and there is varicocele with normal parameters of the semen, you can do DNA fragmentation test. If the high DNA fragmentation, go for varicocelectomy. Definitely, yes.
Okay. Do you have any cut line in this for that? Yeah.
دكتور اسمعني؟
اسمعك.
في كويشن هنا من دكتور خالد يباست اللي هو للدكتور عماد about the role of hydrocele. دكتور خالد he asked we still يعني ensure our patient that there is no relationship between hydrocele and infertility. دكتور عماد mentioned that the hydrocele has a negative effect on fertility. دكتور عماد معنا؟
معك دكتور أكرم.
دكتور
السؤال موجه لك من الدكتور خالد الكحياني. What about the role of hydrocele?
معلش سؤال تاني معلش.
Yeah, he mentioned that he ensure his patient that there is no relationship between hydrocele and infertility. What is your opinion about this? Is there any relation between the hydrocele and infertility?
معلش أنا عندي مشكلة في الصوت لسه مطلعها. يعني السؤال معلش.
دكتور عماد إذا رحت للكويشن and answer حتلاقي السؤال about the hydrocele.
Rule of hydrocele.
Rule of hydrocelectomy, yes.
Definite hydrocele has an effect on spermatogenesis. والموضوع ببساطه جدا احنا يعني لغايه دلوقتي يمكن في الليتريتشر ما حدش كتبه كتير، واحنا يمكن لغايه سنين فاتت كان حتى الاساتذه بتوعنا والدوكيومنت لا الهيدروسيل ما فيهوش اي مشكله خالص. براكتيكالي ما احنا شفنا حالات الهيدروسيل دي يعني الموضوع مختلف تماما. هيدروسيل على حسب الديجري بتاعته moderate and advanced or huge هيدروسيل definite has effect. لان الهيدروسيل ده بيعمل حاجتين، بيعمل كومبريشن على التستس وبيعمل انه بيزود درجه الحراره بتاعت التستس، فتبص تلاقي السيمين بارامترز نزلت. ايفن حتى لو فينا حد عمل هيدروسيل كبير، قارن التستس اللي فيها هيدروسيل من التستس الثانيه، ديفينيت هتلاقيها سمولر، وهتلاقيها البلاد سبلاي بتاعها وحش، وهتلاقي التيشو بتاعها مش حلو. فديفينيت الهيدروسيل ليه رول. الكلام القديم ده خلاص احنا غيرناه، والبراكتيكال لو حد بيشوف الحالات دي كتير ويشتغلها كتير اكيد. كمان دي حاجه ثانيه، احنا كنا زمان نقول ان الهيدروسيل ما نعملوش غير لو هو هيوج. لا، هيدروسيل من اول مودريت هيدروسيل ليه افكت كبير، وكل ما بنسيبه بيأثر بشكل كبير. فديفينيت الهيدروسيل هذا الافكت لايك فيريكوسيل بالظبط. الفكره بتاعت التمبريتشر والثيرمو ريجوليشن في الهيدروسيل دوكيومنت موجوده. يمكن الميتابوليك ثيوري بتاعت الفاريكوسيل مش موجوده في الهيدروسيل، لكن الثيرمال ثيوري ديفينيت موجوده.
Dr. Walid, you can continue with the questions.
Yeah, okay. Thank you, Dr. Muhammad. Another questions is for Dr. Haytham from Dr. Khalid Kuhlani regarding the use of mucolytic in the hyperviscous semen. Does it work really?
So the point here is hyperviscosity is really a problem? Is it really affecting natural pregnancy? Is it affecting ART outcomes? This is a controversial point. But you can consider that some patient with having hyperviscosity could be the underlying cause, some sort of infection, because this is one of the reasons that can have infection, especially prostatitis. So it's important to look if there is an underlying prostatitis or infection and treat the prostatitis or infection. Some of these patients with having high hyperviscosity can have some sort of anti-sperm antibody. So it's important to rule out if there's any sort of anti-sperm antibody. Also hydration status, make sure that the patient does not having good hydration status before embarking on the treatment. Now, there is no conclusion clear that this mucolytic can improve the hyperviscosity, and there is no also make sure that there is nothing clearly saying that hyperviscous semen is really affecting the outcome of natural or even assisted conception. But if there is abnormality and the patient there is delayed pregnancy, it is you can give mucolytics. And we do that, but not based on a guideline statements.
Is there any duration you recommend? For how long?
It is a very controversial part, but if you're gonna give it, I give it at least like for 1 or 2 months at least, so I can evaluate. But I will be careful ruling out the other things that I mentioned: infection, hydration, before I embark into giving treatment.
Okay, thank you. دكتور محمد عبد الرسول في سؤال microscopic varicosilectomy. Is the identification of the artery is easy by the microscope?
الحقيقة خلينا نقول let's say that you have to be experienced in microsurgery because the artery is evident, yes, when you use the up to 110 or 15 magnification, X magnification, you can easily see the artery, and you can use also vasoactive material to dilate the artery to make it easy, like tapaverine or even sodium nitroprusside. Any direct vasodilator can make the artery pulsate, and you can see it very easy in microsurgery. Microsurgery is not difficult. However, you have to practice it because the use of a microscope is not difficult. And I encourage every urologist who definitely do cases of varicocele to learn how to use the microscope. And it's not difficult. It needs only practice. You can easily, within 2-3 days, you can identify the artery and you can spare it during surgery.
Dr. Muhammad, are you using the intraoperative Doppler?
Yeah, this is
no, I don't use when you use the microscope, you can very easily identify the artery without micro Doppler.
شكرا دكتور محمد, thank you. سؤال من الدكتورة يوليا الشرفي for دكتور عماد regarding the management of Sertoli-Olli syndrome. دكتور عماد.
Congenital Sertoli-Olli syndrome. What's the meaning of no spermatogenic cell present in the testis since birth, since development? This is a very difficult case, and we no hope for this patient. The other type, which is the acquired Sertoli-Olli syndrome, post-mumps orchids, post-epidermorchids, post-chemotherapy, post-radiotherapy, post-excessive heat exposure, we have remnant spermatogenic cell. We have foci of spermatogenic cells. عشان كده احنا احيانا بنعمل تي سي وبنلاقي سبيرم وبنخزن وبنعمل اكزي وناخد هيستوباثولوجي